Morning, guys. My name's Keith. I'm a pediatric dentist. I went to USC for undergrad. I went to Boston University for residency. I started working with Brandon with his preveneal crowns probably back around 2012, 2013, initially, or maybe even 2011. And I started making the jump over to Zirconia probably around 2013 a little bit, but more 2014. And I'll be honest with you. I'm not the most, I'm not the perfect zirconia doc, but tell you what I've done and what I've improved upon and what I found along the 5 years that I've used this. So my email is just on the lower right. So I'm always free and available with any case that you specifically have that you have questions about and how to do. I'm more than happy to share my insights on how to do this. If for example, if anybody who has not done this before, I think the most important thing and the most pediatric dentists have apprehension on is, how to place these crowns and which ones is the right one to try. And I'll be honest with you, these cases where they require some type of full coverage crown, they're not easy cases. Your behavior management has to be, you have to be on top of your game in order to do this. As far as the anteriors, any single lateral or single central will be generally easy to place. As far as this particular slide, this really illustrates which case you should pick in terms of your first case. Obviously, if you're in a scenario where you're under general anesthesia and you have a luxury of time, a 4-unit case is generally doable. Just try not to prep all 4 of them at the same time. It gets a little more difficult when you get to situations where you have a 4-unit case with space loss or a 4-unit case with a class 3 occlusion. In the posterior, I would say a lower first would be the best, easiest in terms of trying it out. I would say I do a lot of those particular cases with nitrous only, and it gets harder with the second molar. And it gets even harder with a side-by-side or even with space loss or even opposing crowns. But once you get, I would say, past your first 10 to 20 crowns, it gets easier, and you kind of understand the logic and the protocol and the system that KinderCrown has available in order to fit these crowns. So let's go through the anterior crowns first. A single lateral anterior placement. This particular case was done back in 2017. This is a 3-year-old. I didn't know whether or not 2G was going to be a crown or it was just going to be a composite. I gave worst case scenario to mom. I was probably a little too aggressive on prepping out the decay. And as you see, she had also posterior decay. So when I prepped it out, it was a very ideal case. And you can see that her gingival health is actually pretty darn good. And so you don't have very much bleeding in this case. You can see the ideal prep is really about 1 millimeter to 1.5 millimeter axial reduction all the way around, and probably about probably more like a 1.5 incisal reduction, as well as taking out the cingulum. You see, I did do a pulpectomy, and when you look at the specific the photos on below, this happened to be a case where I have universal and contour crowns. In our office, we generally have contour crowns, but I would say if you look at the crowns side by side, honestly, I tell you, it's not going to make too much of a difference. And so, if you were a first-time user, first-time buyer, I just go with universal. I think you can't go wrong, and you have less inventory that you have to deal with. I was just very particular when I was, 5 years ago, I was more particular about these cases that I wanted contour to have better aesthetic quality to my restorations. So if you look at 9 months, still looking pretty good in the mouth. Obviously, I had very good axial, very good wall height on this particular tooth. And so I wasn't really worried about retention. Obviously, when you're doing these teeth, you're relying upon mechanical retention as well as the chemical retention of glass ionomer. So this is at 9 months, still matches pretty darn good to the existing dentition, and this is 27 months. So this illustrates a single central anterior placement. So this was done back in literally this last year, and I actually saw this kid probably 2 or 3 months prior, just for an initial exam. And it was, obviously the child was very apprehensive, but we got a chance to, create a relationship. But literally about 3 months later, the mom came in with the child and ended up having, hitting the textbook, hitting the tile flooring in the kitchen, and fracturing tooth number F. And you can see, if you look very closely, the pulp is kind of just glaring right at us, right towards the distal part of the fracture, or distal facial part of the fracture. And I gave mom options, and the long-term prognosis was poor if we just left it alone. And it was very acceptable just to go ahead and extract this tooth, but the mom wanted to save it. So the only way we could save it on a 23-month-old, I'm not that great at my oral sedations younger for kids younger than 2, but I'm great at 3 and 4. So we recommended general anesthesia. In about 2 weeks, we got lucky, we got a cancellation. So this is the pre-op and this is the post-op. I ended up using a short crown for this particular case. Even though it was short, you can tell that in this particular case, the kids, the clinical crown that you see on the tooth E, it's only showing 60% of the tooth. And so when you prep, you really have to prep back the gingiva all the way to a full clinical crown size. So, if you look at it, I would say from 60% of the clinical crown down towards the incisal, I think it looks pretty good. But obviously you're gonna end up having to show the coronal margin towards the gingival portion. The lucky thing for this is I was able to get 5 months later, you can see in the smile line, I think it looks pretty darn good. Obviously the gingiva is healed back pretty nicely. And obviously the crown is going to be a little bit thicker compared to the original sizing of the natural tooth structure. But overall, I would say this is a pretty good outcome. Single canine emplacement. So this particular case, again, was done in 2019. Most of the structure of the tooth on the facial and also the incisal and the lingual was very much compromised. There was additional decay on other areas, but I really wanted to focus this particular case just on the canine. I was probably about 1 millimeter, 2 millimeters away from the pulp. We were able to get her in the OR about 2 months later. I did a crown on S and also actually on C. It was a size 2. And so you can see, I think this is actually a universal crown. And so you can look at and compare side by side the buccal lingual or facial lingual mesial distal reduction. If you just look at where the heme is or where the blood is, it's really a very aggressive reduction. Millimeter, 2 millimeters axial reduction, as well as a 1.5 millimeter incisal reduction and reduction of the cingulum. I got lucky and I didn't have to pulp this particular tooth. And you can see, according to the bite, I was pretty close, not only for the universal crown on the lower, on S, but as well as the universal crown on the canine. And then this is 7 months later. You can see on the x-ray, I did leave a little bit of excess cement on the mesial of tooth S. But on tooth C, everything generally looks really good, and the bite bite looks really good at this point in time. Patient doesn't report any pain, and I think it was a pretty good outcome. 2 central anterior placement. So this particular case was done a little earlier, back in 2016. You can see there's probably about a 0.5 millimeter space loss in between mesial distally on tooth E and F. There was multiple caries, not only in the posterior, but also the anterior. The mom was only worried about the anterior teeth. I did recommend general anesthesia. However, she just really wanted to fix the 2 front teeth at this point. So please keep in mind that these photos, they are actually intraoral photos. They're not point and shoot camera photos, so I apologize for the quality. But as you can see, I was able to do the oral sedation in 2016. A lot of people ask me what I use for oral sedation. I use a triple cocktail. I can go into more detail later. Obviously, that's not the focus of this presentation. In any case, I ended up having to do pulpectomies on tooth E and F, and I placed regular size crowns, size 3 crowns on both E and F. And this is the immediate post-op cementation. You can see that I really traumatized the gingiva, and it looks purple and blue. It's always going to look like that when you first prep. but it gets better over time. It also depends upon the patient's gingival status, gingival health. This is 12 months later. As you can see, I would say the gingiva healed very nicely. I think the adaptation works really well the bile adaptation of zirconia works really well in the mouth. You can also even see my size of crowns. And then this is 43 months later. And so this is almost past 3+ years, and everything's working out just really nicely. We got really good resorption. There's no periapical pathology, and it looks like they're going to exfoliate probably within the next couple months. This is a 3-unit anterior placement. The reason why I wanted to show this case is like I mentioned before in the single central cases, sometimes it's really hard to actually match the existing untreated natural dentition. And so this happened to be a 2-year-old in 2015, and this was done under general anesthesia. I apologize. I started prepping to F prior to starting to take photos. But as you see, both D, E, and F are generally compromised. G was generally, it was natural tooth structure. And we ended up doing a full mouth rehab under general anesthesia back in March, a month later. And so this is the immediately after cementation. Again, I was pretty aggressive on the prep design, and you can see I was able to cement it. Immediately, I would say the crowns look a little bit more opaque than a natural dentition. And then this is 1 month later. And from what I can tell you, clinically, I think they look awesome compared to the original. The only thing I would have probably done better was on tooth D. I probably would have taken off a little more cingulum because I think it's flaring out a little more facial. This is another particular case in 2016 that I did. Is 4-unit anterior case. This was a particular case where, I think I wouldn't fault any pediatric dentist from just going ahead and pulling off 4 anterior teeth. Parents were dead set on trying to fix it. Based on the x-ray, based on clinical evaluation, there's no periapical pathology. And I told the parents, I can't give you any promises, but we'll try and fix it. Tooth D was very much at the gum line when it came to whatever was left of the tooth afterward. And, everything above the gum line is generally very mushy. And so I ended up doing an OR visit in September, about 4 months later. These happened to be regular sized crowns. The reason why is because I wanted to grab as much tooth structure I could below the sulcus. And keep in mind, when you actually prep these teeth, you're actually going to be prepping down to about 2 millimeters beyond the gingival line. And so, if you look at the x-ray, you probably have a good 2 millimeters of wall height in order to grab, in order for these crowns to retain. And no, I did not use any post and core. I didn't use any buildup. I went ahead and did my apoplectomies and just used the existing tooth structure as my retention along with key tap. This is post-op 1 month. I think it looks pretty darn good. I think the teeth, they still have the teeth and the gingiva, the crowns and the gingiva still have a little more time in order to adapt to the existing natural tooth structure. And then this is 12 months later, and I think it's looking really good. You can see that you're starting to get some resorption characteristics of D, F, and G, and some movement. You can see some spacing of E and F that wasn't there 12 months prior. And then this is 24 months, and then this is 30 months. And so I would guess that on tooth D, I would say it's probably another 6 to 12 months before it's going to exfoliate. And I think this is a pretty awesome outcome. And I think a lot of pediatricians worry about on these specific crowns. And I want to tell you, in this particular case, I think it's just fine. I think it works out. If your prep design is good, and your treatment planning is great, you have no problems with retention. I don't know about any of the other crown systems, but this one is specifically goes to show that you really don't need that lingual retention that you used to have on preveneal crowns, where you bend it on the lingual in order to keep the crown on there and get that snap. This is really a passive kind of fit on these particular crowns. This is a specific class 3 case, and This was a particular case that a couple of pediatricians asked if this can be done. And yes, it can be done. The only downside is obviously you can't turn it into a class 3. This was done in 2017. It was a 3-year-old. We prepped it out. And then I ended up using regular size crowns. The interesting thing about this case was that his teeth were generally a little more narrow by comparison to what crown sizes that we had for essentials. So what I ended up doing instead is I ended up using large laterals for my essentials. So I used size 5 laterals for my essentials, and I used size 3 laterals for my regular laterals. And so as you can see, I was able to gain probably about 0.5 millimeter to 1 millimeter of space, or making them more narrow in order to get everything to fit. And then this is 4 months later. I see the bite kind of settled. Again, I can't fix the class 3 occlusion, but generally I think it looks pretty darn good. And then this is 22 months later. And still, I don't have I'll probably see this young man about a few months from now. So we'll see what it looks like at that point in time. So the big pearl about doing the anterior cases is that if you're using these crowns and you have multiple crowns to do in the anterior, my recommendation to you, if it's one of your first times, and even today, I still only prep 1 to 2 teeth at a time, so that I can always match the existing anatomy or the existing height and overall tooth structure of the original natural teeth. And so in this particular case, I already prepped tooth F, and tooth E I left untreated. And so you can see this is a very ideal prep design. And then I ended up going ahead and prep tooth E in the same fashion. You can see side by side, they're generally the same. And then this was cementation. I used Key-Tac. Honestly, tell you, I would say that Key-Tac, that viscosity right there, it's a little too wet for my taste. And I'll be honest with you, about a year later, there was a little bit of graying of, I think, one of the crowns. But I did check the occlusion on this video case. And I think occlusion, the big story about zirconia is getting the fit and getting them to last and getting them to look good is obviously retention and fit, but it's also occlusion. You really have to adjust the occlusion to make sure they're going to last, and you're not going to have any, how would I say, long-term pathology. So picture things about anterior zirconia tips. Try to pre-size before you prep. Don't, prep it and then start looking. Otherwise, you're going to end up having about 10 crowns to sterilize afterward. Essentials, I want to say contour is better, but honestly, I tell you, both cases, essentials and laterals, you can use universal, and I think it'll be just fine. Multiple crowns, again, I would just try to prep contralateral teeth. So say, for example, I'm right-handed. So typically I start on the left side on my OR cases. So I'll do E and G first, and then I'll go ahead and put D and F afterward. A lot of pediatricians ask me about hemostasis. Honestly, I tell you, I still use a little ferric sulfate, but if you don't have it, just pressure and time helps a lot. And so what happens is I usually end up prepping the anterior teeth on the left side first, then I let ferric sulfate set. Then I'll do the left posterior teeth. Then I'll go ahead and swing to the other side, do my anterior teeth again, put some more ferric sulfate to get it set. And then I go ahead and do my posterior teeth in the right side. And at the very end, if I have to do any pulp endo treatment for the anteriors, I go ahead and do it while my assistant is cleaning and preparing the crowns for cementation. As far as multiple crowns, like I said before, universal is definitely just fine. In terms of space loss, when you get some drifting of the teeth, you can use lateral crowns for essentials. Sometimes you end up having to size down, or you can use a slight distal rotation in order to gain some more space. As far as the posterior crowns, this is an upper first molar placement. I see this 4-year-old in 2016 had multiple caries. This particular case was done in September 2016. I ended up having a pulp tooth number B with a size B2 crown. All I had was at the time, I think I had Brandon had LP crowns by that time, 2016. He can tell you kind of the progression of what he has, but this is what it looks like about a month later. I would say in this particular case, the occlusion looks great. One of the things I had to do in this particular case is I had to reduce a little bit of the natural tooth structure on tooth S in order to get everything to fit back in the OR so that I can get as close as I could. This is a first molar, this first molar placement. This is 5 months later. As you can see, everything seemed to look okay. And this is 29 months later. I did get a little bit of pathology, just in the furcation. But honestly, tell you in the mouth, in the gingiva, I didn't see anything. And at 29 months, this is the ortho consult, and I would say generally everything looked pretty darn good. This is a second molar placement. This particular 8-year-old in 2016 presented with large decay on tooth number A, and I ended up being able to do this during a nitrous appointment. I was impinging upon the pulp. Nowadays, to be honest, would I still do a pulp in zirconia? I still would. The other option is just do a huge composite. You can go either way in this particular case. And I ended up doing a crown on this particular situation. This was 3 months later. In this particular case, one of the drawbacks of what I did is that I didn't have crowns that were smaller than size 2.5. And in this particular case, I would have said probably have a size 2 or 1.5 available, because one, on the occlusion, I had to reduce a little bit on tooth T in order to get the fit. And on the distal of B, I had to take off, do a enamelloplasty in order to get this particular crown to fit. And is it the best? Is it a compromise? Yeah, but I was able to get the crown to fit. And this is 21 months later, and still looking good in the mouth. No additional decay. Oh, actually a little bit of decay on the distal of tooth B, but it looks like it's going to be exfoliating relatively soon. So this is a good illustration of an ideal prep for tooth number S. Again, in particular case, in certain situations, some pediatricians will choose to do MOD instead. In this particular case, I ended up doing a crown. And so you can see in August, the patient presented as a new exam. In October, we were able to get him in the OR. And I ended up using a size S5 crown for tooth number S. This is the occlusal photo and also a buccal photo. This is the prep design. Again, it's 1.5 millimeters all the way around. Please keep in mind you have to really take off that buccal bulge in order to get these crowns to fit. And I ended up doing class 2 on tooth number T and also class 3 on tooth number R. This is what it looked like. I would say this is a little high, but generally fairly acceptable. And this is during the post-op. You can see the occlusion on tooth C compared to tooth S. Generally, it looks pretty good. And I'm sorry the photos were a little out of focus. Some of these kids have a hard time holding still, as you guys would know. And then this is 4 months later. And I didn't have to pulp this tooth, and it generally looks pretty good. I didn't leave any cement in this particular case. So this is a really good case to present in regards to space loss and how to deal with it in the posterior. So this was in 2016. Brandon didn't have a lot of the universal posterior crowns at this time, and it was just I would say it was the original crowns that I got with him, and so they're generally contoured. This particular female presented in September of 2016, 6-year-old. We got her in the OR about a month later. And so I drew some lines in so you can kind of see where, the prep design versus where the original tooth was. This kid happened to be a grinder. And so when we prepped, you can see it's about 1.5 to 2 millimeters of occlusal reduction and about 1 to 2 millimeters of axial reduction all the way around. And this particular case, I ended up having to pulp. And so you can see the axial reduction is generally fairly aggressive. I would say it's more aggressive back a few years ago as opposed to universal crowns that Brandon has today. But the principles are generally the same. The biggest thing about the surgery case is that you end up having to, when you have space loss, you end up having to compensate for that by either doing a class 2 or doing a crown and also the adjacent tooth, the adjacent second molar, to really push back that marginal ridge, and so that you can get correct path of insertion for tooth number I. And so I would say with that mesial drift, it was a 0.5 millimeter mesial, so you have to really draw back half millimeter to a millimeter in order to get everything to fit. And then this is 2 months later, 7 months later, 22 months later. And so I would say by December, the patient lost a tooth and everything was just fine. This is a little shorter, but it's still, I would say clinically, this is very successful. A lot of pediatricians ask me whether or not I usually do the class 2 first versus the crown first. You can go either way. I've done both ways. The only recommendation I would give you is make sure when you size the crown, make sure you have enough space to get your tophomire or your T-bands in between the crown and the tooth next door, so that you don't have to end up going back and messing with your box design so you can fit that tophomire or the T-band in there. So this is a particular case. This is a posterior side-by-side case. A lot of pediatricians asked me about these particular cases, and I ended up doing one back in 2016 in October. You can see the large decay that was on S and T in October, and then I ended up doing an oral sedation, and then I ended up pulping tooth S and tooth T, and you can see the occlusal height. This is the prep design. Again, these were the original crowns, so keep in mind, this is a very aggressive prep design. I would say, compared to the original teeth, you're probably close to, I would say 2 to 3 millimeters of space between S and T, and a very aggressive occlusal reduction almost to the gum line towards the distal of T. And at the time, I was worried about retention on these crowns, and so I was placing less zinc oxide eugenol, or I actually used Tempet in the internal so that I can get some more cement in the internal. But nowadays, honestly, tell you, it doesn't matter. And even if you do prep equigingival to the almost equigingival to in terms of the inside occlusal reduction, you'll still get retention, and it just seems to work. This is cementation, and so you can see I did adjust some occlusion on the opposing teeth in order to get everything to fit. And then this is 7 months later. So I did get a little bit of mesial tip, and I didn't realize that, but as far as occlusion goes, it still looked pretty good. One of the things you should keep in mind is, as you look at these radiographs, back in 2016, 2017, I was cutting dry. And that's one of the big tips now, is that I feel like you should be cutting wet now. And I'll show you later slides in regards to that. This was 19 months later. And this is 31 months later. And so you can see I've been getting a little bit of periapical pathology on tooth number T. Is it terrible? I don't think so. I don't see it in the mouth, so I'm willing to wait on it. On tooth number S, I think the pulpotomy that we did looked generally very successful. You can see a narrowing of the canals. This is another side-by-side case. You can see a mesial drift of tooth K. I ended up seeing this kid in June of 2017. I ended up going to the OR about a month later. And we ended up having to pulp both K and L. And then I used size 4 crowns on both. You can see, again, my prep design, you're almost down to the bone. And I know it's really aggressive. And you are going to get some pathology. But I'll be honest with you, these crowns were a lot more narrow, I would say, a few years ago, and they would say they're a lot more forgiving at this point in time. I don't think you're going to have to deal with the prep designs that as aggressive as that. But again, I would say this is a work in progress, and it looks a lot better now. This is about a month later. The patient did report a pain. As you can see, I did do a pulpectomy on the mesial root of tooth number K. I did have some excess cement. Honestly, clinically, everything looked okay. I attributed it to an erupting 6-year molar. This was 21 months later. Just for everybody that has a question about what happened to that 6-year molar, it ended up that this particular child had MIH on 3 out of the 4 6-year molars. It looked pretty aggressive, where we would end up having to take him back to the OR again in order to crown them. I gave parents the options to go ahead and pull all 4 of them with oral surgery, or trying to restore them with stainless steel crowns. With this, they felt like it was such an ordeal having to go through full mouth rehab. They opted to go ahead and pull the 4 6-year molars. This is 21 months later. In any case, this is a third case. I happened to do this under nitrous. I would not recommend doing this under nitrous for anybody. Although I got this done and the patient was very not compliant, but very cooperative, I would say I got really lucky on being able to finish this case. And you can see there's a lot of close to 1 millimeter space loss on tooth A and B. I would say the caries was impinging upon the pulp. I did this about 6 months ago, and then this is what it looked like immediately start to finish. I probably got this done in about 35 minutes, but I was in a hurry. And so I ended up using universal crowns. I would say the prep design, you still have to go circumferentially about 1 millimeter, 1.5 millimeters all the way around. I would say it's about a 2 millimeter reduction. And as you can see, I was probably high by about 1 millimeter on tooth A after I cemented. And I took an immediate post-op x-ray. You can see I left a little bit of cement. I ended up having to do a pulpectomy on tooth A, or partial pulpectomy, but generally everything looked pretty good. This is a particular case that you can see that when you have all of the crowns available, sometimes you end up having to use, I know in stainless steel crowns, I ended up having to use the upper crown for a lower crown called contralateral sign. So this particular case illustrates that you can do that. In 2017, I did this. It was oral sedation. I presented in December, did in February, and I ended up having a pulp tooth I, and I placed a size 4 crown. Oh, actually, it's not tooth I. Sorry, take it back. It's actually tooth S. My apologies. Tooth S, and I'm using an I4 crown. And this is 6 months later. Everything looked good in the mouth. And then this is about 13 months later. It seems like I'm getting a little bit of pathology on the furcation, but I didn't see anything clinically, so I decided to wait. I should have a new slide about new x-ray probably later on this year. So big picture, first molar, pre-size. Use your mesial distal teeth as guides if you can. More likely half sizes with space loss. You can use a contralateral upper to put it on the lower. If you do in fact end up pulping these teeth, you're able to get less occlusal interference. But nowadays, I'll be honest with you, with the improved design that Brandon has, I generally don't have to pulp that many teeth. I get pretty close, and I end up doing pulp caps a lot more now. As most of the seasoned pediatricians are doing now, it seems like the less endodontic treatment you do on these particular teeth, the more success rate, the higher success rate you have. Second molar, again, use your mesial tooth and the posterior anatomic landmarks as your guide reference. Some mesial tipping is okay. It seems that occlusal equilibration happens over time. Opposing or side by side, try to avoid having to do a crown on the second molar. Try to do composite as best you can, or amalgam, it's fine. Pre-size, consider prepping 1 molar at a time when you first start. And you're gonna have a higher incidence of occlusal interference when you have no endo treatment. And that's, if it's a 1/4 to 1/2 millimeter, I think you're gonna be fine. But once it gets to about 1 millimeter, you're gonna have a lot more pathology, long-term pathology, probably within about a year or 2. Full mouth rehab with zirconia. Um, and I didn't start doing this until a year or two into it, of placing these crowns, because it did take a lot of time. But once you get the hang of it, some cases just come out pretty darn awesome. And so this particular case is a 3-year-old, 2018. Again, I would tell you, any pediatrician, if you wanted to go ahead and pull the forefront teeth, I would have no problem with that. This particular case, parents were dead set on trying to fix it, so I said, okay, fine, let's go ahead and try it. So you can see there's multiple teeth. I would say B to I ended up crowning, and I think to T I ended up crowning as well. So see the sizes of crowns. This is 3 months after, during a recall appointment. I would say this is a great portfolio for me to go to extreme makeover for any child. I'm kidding. But in any case, I ended up having to pull several of the teeth, and I would say they're holding up okay for 3 months. Obviously, the telltale sign is to get past to 1 year. And it happened that I got a year and 4 months. And so, the D and F and G, they're still in. Am I getting normal exfoliation characteristics with E and F? Yes. And it seems to be holding up pretty darn awesome. We'll see if this lasts another year, but it's looking pretty good at this point in time. This particular case, again, it's another 3-year-old in 2018. A lot of pediatricians asked me whether or not, will these crowns cover the SDF treatment that you did previously? I'm going to tell you, yes. I've done it every single time. Do I think SDF is a go-to? No, I think it's just a stopgap. It's just to give the parents a little more time to think about whether or not to fix the teeth or just to go ahead and pull it. This particular case, I ended up having to treat E and F and L and T. This is 9 months later. So you can see on the anterior, I would say it looks pretty darn good compared to what it had in the first place. On tooth T, I ended up having to pull up. It's funny because tooth S, the decay looked terrible, but I was able to save it without too many problems. And then on tooth L, I ended up having to pull up in both the lower crowns. You can see that they're universals, and they're looking just fine. This particular case was the third full mouth rehab case that I took photos on. This is done in 2018. In February, I saw the child for an exam. In June, I ended up doing an OR visit. And you can see, yes, there's a mesial dens. I recommended parents to pull E and F. They didn't want to, they wanted to save it. So we went ahead and fixed everything. This is what it looked like clinically in the posterior for tooth T, L, and K, and E and F. And so these are the particular crowns I ended up using. I ended up having to do more crowns in the posterior. Some of them I did pull, some of them I didn't. Same thing in the anterior. I ended up doing pulpectomies. In general, the interesting thing about this case is I ended up using both universal and contour crowns in the posterior. So you can see on tooth K, I ended up using a contour crown, and then tooth L, you use a universal. And on the other side, on tooth S, I used a contour crown, and then tooth T, I ended up using universal. And the long story short about this is that I'm transitioning all of my crowns over to universal because I don't think it makes a difference, and the outcome looks really good. But if you had to mix and match, it still looks pretty good, to be honest. And then 12 months later, this is what it looked like in the posterior. I am getting some periapical pathology on tooth L. The reason why I saw this kid back in 12 months later was because I ended up having to pull E and F and also the mesial dens on the anterior. But this was a referral from Western Dental. And so this is what I did for them. This oral sedation, this is a 2-year-old oral sedation case. 2-year-old multiple decay. I recommended full mouth rehab. Unfortunately, the parents instead opted to do SDF and sedative to hold off for tooth S. Later on, about 5 months later, this is what it looked like. I put the temporary on S. Still getting more decay, aggressive decay on tooth B and I, again, kids gonna let me incidents. But you can see the aggressive decay that she had on B, I, L, and S, and as well as F. At this point in time, in June, the parents finally were okay with go ahead and doing a 2-part sedation. And so you can see on the first sedation I did in November, or no, actually I take it back. In November, I did the second oral sedation, but I was able to show, and so this is what it looked like during that second sedation, pre-op and post-op. As you can see, I'm a little high by about a millimeter, but I was able to also take photos of the sedation that I did back in September, and I ended up not pulping any of the teeth. And this is the immediate post-op of what it looked like. Again, I ended up using a lower a B crown for tooth L, and immediate post-op looked really good. And like I mentioned before, I was high about a millimeter because I chose not to pulp these teeth. I think the only tooth I ended up pulping was B. But about 6 months later, if you look at the occlusion, everything equilibrated. It happened that this tooth, the kid had trauma on tooth D, and she lost it on her own. I didn't end up, and it ended up not having to pull it. And then this is the post-op X-rays. And did I pulp? I don't remember if I pulped. Maybe I didn't pulp tooth B. But in any case, if you look at the post-op X-rays of all 5 crowns, everything seems to look okay. And it look, there's no periapical pathology. My occlusion has, adjusted on its own, and I think this was a really good outcome for the kid. Would I have rather done this under general anesthesia? Absolutely. This is another particular case. This happened to be a patient that, I want to say it's enamel hypoplasia or, some type of dysplasia on 3 teeth on B, L, and S. At the time, she was only about 2 years old, 2.5, 3, and she was very underweight. And so I was not ready to tell her to do anything just yet. I ended up doing a oral sedation back 4 or 5 months later. As you can see, I placed STF and glass armor all over the place to try to hold everything together. And then this is 7 months later. And as far as go, everything looked really good. I ended up using a series of universal crowns in this particular case. Initially, I want to tell you on tooth L, I did not pulp it, but the parent was very concerned. She actually happens to be a healthcare provider. She's worried that there might have been an abscess. So we went ahead and went back again under nitrous, cut off the crown. I looked inside, pulped it. I didn't see anything. So I went ahead and did a pulpectomy, and it was generally very healthy, and I replaced the crown at no charge, and it still looks good today. So this particular case, I just wanted to share. It's a enamel hypoplasia case I did back in 2015. It was A, G, K, and T. Honestly, tell you, I would rather parents be okay with just doing stainless steel crowns instead of zirconia. This was the case where I could have given up on zirconia. It almost took me 3 or 4 hours to do this. We got it done back in September of 2015. And then this is 45 months later, and I didn't have to pulp any of the crown teeth. This kid is a grinder. I would say the crowns are a little oversized, but in general, the gingival health, the periapical health, the overall tooth health, the teeth are generally okay, and it's coming out. I would say I'm not going to have to worry about any retention issues, obviously, and I'm not going to have to worry about any periapical issues of these crowns. And they're going to exfoliate probably in another 2 or 3 years. Custom Zirconia case. So this particular case, this is man, I'm married to this case. This is a terrible case to consider even doing. But in any case, this is a June 2016, 10-year-old cerebral palsy in a wheelchair, had trauma to tooth number 8, and caries on the posterior teeth. This is what number 8 looked like. So I ended up doing basically a composite crown, 2016. He decided to break it in November, and then I had to do a direct pulp cap, broke it again, and having to do a root canal and a post and core that I borrowed from my general dentist down the street, and I ended up doing an endo. I only end up doing 2-3 endos a year, just because my endodontist doesn't have OR privileges, and I ended up, no endodontist wants to do any cases under the age of 14, so I get stuck with them. So this is what it looked like. 2018, I told the parents, be very careful. Obviously, they're not very careful. They fractured it again. About 7 months later, I talked to Brandon. He said, yeah, just go ahead and take measurements. I said, okay, we'll try iTero scan with the dad's help and 5 assistants in the room. We were able to get a decent iTero scan, and this is the crown that Brandon was able to prefab. So I asked him to just go ahead and just do it in A2. And this is what it looked like pre-cementation and pre-OR. And then this is what it looked like during the prep. There's some glass armor that I threw up on top, so just to keep it nice and protected. During time we were waiting for the parents to do it and the crown to be fabricated. This is the prep design. Obviously, you know, this is not going to be perfect. You know, it's a prefabricated crown. You know, this, kind of melts along the lines of general dentistry and also pediatric dentistry. But, I had to get the prep the tooth to fit. And so I'm not going to expect the margins to be perfect. But what I do expect is, if I can get 4 to 5 years in the pediatric dentition of retention and also color and good occlusion, I think I can get 5 years out of this one. And so this is what it looked, immediate cementation. I would say I could have probably prepped down a little further, but I also wanted to retain a lot of tooth structure. So you can see there's a little bit of show of the CEJ on the facial as well as on the lingual. And this is what it looked immediately post-op on the x-ray. I was able to get an x-ray, and then I was able to get some photos inside, again, with 5 assistants, with dad and me all at the same time. So I would not recommend anybody to do this, but if you love your patients and want to go the extra mile, this is probably a case that Brandon and Todd can really help you out on. So clinical pearls, big picture things: burr selection, cement choice, what to do with cement leakage, sizing issues with space loss, outcomes of incorrectly seating crowns, endodontic options for primary teeth. Burr selection. Oops. In any case, this particular slide shows you what I use. I end up using an 8 round burr diamonds for most of my occlusal reduction, as well as popping into the pulp. I am using a flute ball a lot of times to take off the cingulum. And I have a short and a long flame diamond burrs. And I just happen to use Brasseler. So if you want the particular numbers, they're right there. I'm not advertising for Brasseler. That's just what I got used to using. So cement, you can use any cement that you want. It just happens that I use Keytac. So usually 1 scoop to 1 drop is generally okay. If you want to add a little bit more, I think it's better. And I like the thick doughiness of a drier cement. You have less working time. That's true. It's about 30 seconds. But one is you can push all the blood out of the way of the sulcus, and you have a short working time. And you really want these crowns to set. You do not want to wash the cement off. Let it set. Move on to your next cases, next teeth, or go ahead and let it have a patient bite down. Let it set, and then go ahead and let your assistant floss it out and take out any of the excess cement. Don't wash it out. If you're gonna wash it out with spray and water, you're gonna get a lot of washout, and the crown's gonna turn gray. And so again, back to the story about washing out. This particular case, I was a little more cavalier as far as my initial cases, and I washed them out very quickly. I ended up doing 2 or 3 crowns, zirconia crowns, and an oral sedation. And as you can see, there's some washout on tooth A and tooth L. I oversized tooth L. And again, I know for this particular case, I ended up prepping dry, and I also ended up rinsing out the cement as soon as I could because I was in a hurry. I only had an hour to do the sedation. But clinically, would I have to replace these? I would say this kid needs ortho. So I think it looks just fine, and I wouldn't change it out at this point. But if the parents want to change it out because of what I saw, I would be more than happy to change it out at no charge. Cement washout in the anterior. This particular case I did probably about 2015, 2016. You can see the large decay between E and F. This was immediate post-op. Everything looked good. Unfortunately, about 6 weeks later, tooth F ended up washing out. And so I went ahead and redid the crown at no charge. I think the big picture about this particular case is, one, you can take off the crown. Just go ahead and use a diamond burr. It's usually a fine diamond burr that you're supposed to use. Sparks will be flying, so you cut when you're cut wet. Use a lot of suction. Obviously, don't do what the pediatric dentist did in Las Vegas and burn the back of the mouth. As the case, I think it just showed up about a couple months ago. I'm sure you guys read about it. In any case, crown removal. If you look at how we took off the crown, you can see the immediate gingival adaptation of the crown, and the gingival health looks really awesome all the way circumferentially around. And I think it spells two. One is the glass ionomer cement, and two, the adaptability of these crowns to the gingiva and how healthy it looks compared to a traditional stainless steel crown. This is immediate cementation. Again, these are intraoral photos. My apologies. And then this is what it looks like 18 months later. And this is what it looks like 24 months later. So can you take off these crowns? Yes. To repair them, not a problem. Will they still last? Yes. Still looks pretty awesome. Sizing issues. I think the biggest thing about this particular case is make sure you have size 2, maybe 1.5 crowns, or even the largest first primary molar in order to get these crowns to fit. This is a pre-op of this particular case. You can see tooth A, again, had that decay. I think this case, I just showed it, was the previous sedation case where we had the washout. And as you can see, the crown looks a little bit larger than what it should be. And I would say I would have used a 1.5 size crown or a size 2 crown in this bigger case. And you can see it's a little bit bigger than I wanted, and I had to take off a little bit of the distal of tooth B. But 26 months later, everything looked okay. Obviously, it's blocking out tooth number 5, but I think normal exfoliation is going to be just fine. Consider for space loss before sizing crowns. Again, use laterals for centrals. And so you can see this particular case, pre-op. I was a little cavalier in this case, and I told the parents that, we can do this, not a problem. You can see I sized tooth E and G, and this is my prep design. And unfortunately, this is what I came out with, and I'm really not happy with how it looked. Obviously, it looked way better than the originals, but if I were to do this again, I would use laterals. And I would say this is a geographical success story where I haven't seen the kid in the last 3-4 years. I just saw him for surgery, and that was it. Hopefully, they've exfoliated by this time. Dealing with tight contacts. So this particular case, I ended up doing the OR again. You can see the decay on T, E, F, and G. E and F are a little bit more facial compared to D and G. So what I ended up doing is I ended up rotating the crowns distal a little bit in order to get them to fit. The only downside is the E and F look a little bit taller, but generally it's a very acceptable outcome. Second molar placement. If you have the 6-year molar, it'd be great. Otherwise, if you have the luxury of time, take an X-ray. This particular case was done in 2014. This kid had enamel hypoplasia. I would recommend it crowns on the second molars. Parents were dead set on doing zirconia. About 2 nitrous formants, 3 sedations later, I got this. And I was very disappointed in myself. In 2015, that's what it looked like. 2016, the occlusion kind of equilibrated. In 2018, this is what it looked like. I asked Mom if she ever wanted to change it out, and she said, everything looks fine, Doc, we'll just go ahead and let it be. So please keep in mind, if you can take an x-ray or, keep in mind, you may have some tipping if you don't get that distal completely prepped out. It may look like it's normal, but, you really want to get the crown to fully seat. Occlusion issues. Again, this is another particular case where I was very cavalier about using these zirconia crowns, and I didn't realize how much technique involved in order to place these. This particular case I did in the OR a couple months prior. This is a recall that I saw. Everything seemed to look okay until I came in for a learning about a month later. And you can see, when you're opposing any type of composite, amalgam, stainless steel crown, these zirconia crowns will win. It turned that stainless steel crown into a tuna can. And so I was probably high by about a millimeter and a half. And this is why I'm going to tell you, try to be within a half a millimeter of occlusion in order to avoid this particular situation. When I started doing a lot of these zirconia crowns, I thought, oh, it's all good. It's going to be the same thing as stainless steel crown and a pulp. It definitely is not. And so this video case called into question whether I was doing the right thing. This is in October 2015. I ended up doing it in the OR. A couple months later, this is what it looked like. In 2016 and 2017, you can see some periapical pathology on 2017. He actually lost a mesial marginal ridge of tooth K. My business partner ended up doing a pulp and crown on tooth K a few months later. This is what it looked like in 2016 and 2018. So you can see, I don't know if this is specifically the crown per se, whether rather more, it would be the patient's immunology to the materials that I was using inside the pulp. And I would say right now I'm using Tempet and formocresol. I'm not using ferric sulfate or viscostat as a pulpal medicament. But nowadays, I am using MTA and a lot of pulpectomies a lot more. This is another case you can see from 2015. I ended up doing the OR in 2015. And as you can see, a couple of things about this particular case is that I'm getting that ghosting effect on the periapical areas. I also got a cracked crown. This is the only cracked crown I ever had on tooth T. I did lose the distal portion. Brandon can go in more into further detail what you usually sees. I thought this was going to be a failed case for sure, but it turns out, 4 or 5 years later, whether or not the pathology is, it has many things detrimental to the premolars. They're generally erupting. The eruption pattern is generally okay right now, and it seems to be going the distance. Would I rather pull these teeth and done holding arches? Probably, but things seemed to work out, and it was okay, and the parents were okay with this outcome. I'm not happy with this outcome, though. I wanted to do better than this. So this is what I usually do now. I actually have triple antibiotic paste. I have pulpectomy material at my disposal. A lot of people ask me, pediatricians ask me how I do my pulpectomies. I usually have 21 millimeter files, 15 to 40. And then I have bleach, and I have medium or coarse paper points, and endomotor is optional. I use it now. I use Vitapex or Tipex to fill the space, and I use Tempet at RAM to close the cavity prep or the endo prep. You can use sodium. You can use chlorhexidine. You can use whatever you want. I'm just a bleach guy. I want to kill everything that's in the pulp. And so the reason why I'm more into pulpectomies now and other options like MTA and triple antibiotic paste is these early cases that I did. So this was done in 2015. I think it was done during oral sedation. I did have some failure on the distal root of tooth T immediately post-op. But you see in 2017 later on, everything healed and it looked really awesome. And so this is why I'm a big proponent of, having the right endodontic treatment and not just doing pulpotomies all day long. This is another particular case I did in 2015. In 2017 later on, this is another GP referral. As you can see, everything looked really good and I was able to keep the tooth for that child. Big picture things. One is make sure your endo treatment is sound. If you need to go do a pulpectomy or if you need to use triple antibiotic paste or MTA, please do it. You're going to have much more long-term success. The other thing is that go ahead and prep wet. I think we're introducing a lot of heat to the PDL and also the pulp, and that's where I see a lot of failures seem to be happening. I've had much less since I've switched up my techniques, and I still would recommend doing crowns to this day. This is another particular case. Again, this is another posterior pulpectomy where the GP, I had to bail him out, placed amalgam into the pulp, did the oral sedation, able to fix it. A few months later, no pain, everything looked pretty darn good. Summary, bird selection. Go with diamonds if you can. Cement choice, thick mix, you can use whatever you want. I use Key-Tac. Cement leakage. Some crowns can be cut off and replaced if it's not in the clinical smile line. Sizing issues. For anterior, posterior, try to have a full set of anteriors and posteriors if you have available. Adjacent opposing abdominoplasty will help. Using laterals for centrals. Incorrectly seating crowns. If you have any question that it's not going to fit, go ahead and take an x-ray or go ahead and replace a stainless steel crown instead. Endodontic options for primary teeth, prep with water to reduce heat exposure to the pulp and PDL. Correct endodontic diagnosis and treatments to ensure long-term success. And then utilize pulpectomies for posterior for questionable pulp diagnosis. You can also use the antibiotic technique. You're gonna have to call your local pharmacy to see if they're willing to compound that for you. But again, once you step up to providing this type of procedure, obviously these parents are paying a lot of money sometimes for these crowns, and you just want the long-term success that you're going to get 4 or 5 years out of it, not just 1 or 2 years. I'm sure there's a lot more questions, but Brandon can always let me know, and I can always fill it in for you guys when the time is available or at a different time. Thank you very much. And this is my family. Ha ha ha.